Your cartilage is not dead. It stopped getting the signal to repair itself. Those are two completely different problems. And until November 2025, nobody knew which one it was. Stanford just found the answer. And what they found changes everything your doctor told you about your joints. If you've been living with joint pain, if you wake up stiff, if stairs hurt, if you've been told that's just arthritis, learn to live with it, I need you to stay with me for the next 25 minutes. Because that advice, it was based on a belief that science just proved wrong. For decades, doctors told us cartilage was a dead end. Once it wore down, it was gone. No blood supply, no nerves, no way back. And honestly, they weren't wrong, based on what they knew at the time. But here's the thing. They were missing a piece, one specific piece. And when Stanford found it, published their findings in one of the most respected scientific journals on the planet, the whole story changed.
Today, we're going to tell you exactly what they found, why it matters more for women over 60 than anyone else, and, most importantly, what you can do about it right now before any new treatment even hits the market. We are not going to give you a list of supplements to buy. We are going to give you the real picture, backed by the research, and let you decide.
By the end of this video, you will understand your joints better than most people who've been living with pain for years. And that knowledge, that reframe, changes what you do tomorrow morning.
Hi, I'm Suki Yamamoto, wellness specialist.
And I'm Marcus Reid, your senior health coach. No fads, no miracle claims, just what the research actually shows and what it looks like in real life. Let's jump into the studio.
Let's start at the beginning, because most people have been given a cartoon version of what arthritis actually is. And the cartoon doesn't explain why the new research matters. Your joints, your knees, your hips, your shoulders are engineering marvels. The ends of your bones are coated in a smooth, slippery tissue called cartilage. Think of it like the rubber bumper at the end of a chair leg. It protects the bone underneath from impact. It lets the joint move without friction. Without it, every step would be bone grinding on bone. That is actually what happens in advanced arthritis, isn't it? The grinding sound. That is exactly what happens. But here is what most people don't know. Cartilage is designed without a blood supply. No blood vessels run through it. That design is intentional. Blood vessels would make the tissue unstable under pressure. But that design comes with a cost. It can't fix itself easily. It has very limited ability to repair itself. And as we age, that ability drops dramatically. By the time you're in your 60s, your cartilage cells are working at a fraction of the capacity they had at 30. The tissue thins, the cushion shrinks, and the joint starts to feel it. Now here is what I always thought. I thought that was just wear and tear, like an old car. The parts just get used up. That is the belief most of medicine has operated on for 50 years, and it is only partially true. Yes, there is cumulative damage over a lifetime of use, but the Stanford study says that's not the whole story. The reason your cartilage stops repairing itself as you age is not just because the cells are worn out. Something is actively switching the repair system off. Something is turning it off, not wearing it out, turning it off. A specific enzyme, one that builds up in your joints as you get older. And as it builds up, it blocks the signal your cartilage cells need to do their job. We will get to exactly what that enzyme is in a few minutes. But first I want to explain something that doesn't get talked about nearly enough. Why women over 60 are getting hit so much harder than men. Because if you're a woman and you feel like your joint pain got significantly worse after menopause, you are not imagining it. There is a biological reason. And knowing what it is changes everything about how you approach this. That's coming up right after this. Here is a statistic that most people don't know. Before menopause, men and women develop arthritis at roughly equal rates. After menopause, women's rates shoot up. Women develop arthritis more often, experience more severe symptoms, and have worse outcomes than men of the same age. That gap is not small. It is one of the clearest patterns in all of rheumatology research. And the explanation is estrogen. Estrogen, Most people think of it purely as a reproductive hormone, something to do with cycles and fertility, but estrogen receptors have been found on cartilage cells, which means estrogen is not just doing reproductive work, it is actively involved in joint maintenance. So estrogen was protecting the joints all along, and we didn't know. It was doing several things simultaneously. It was helping your cartilage cells produce the proteins that keep the tissue strong. It was slowing down the enzymes that break cartilage down. And it was keeping the inflammatory environment inside the joint calmer and more stable. And then menopause happens, and all of that protection disappears at once. All of it. Simultaneously, the cartilage becomes more vulnerable to damage, the inflammatory signals in the joint become louder, the repair capacity drops. And this is where the Stanford findings intersect with the women's health picture. There is strong biological reason to believe that estrogen withdrawal and the specific enzyme Stanford identified are working against you at the same time. Same outcome. Two different mechanisms, both triggered by the same life stage. So if you're a woman in your 60s and your joints hurt, you're not just dealing with aging, you've lost your natural joint protection at the exact same time this aging enzyme is rising. You're being hit from two sides. That is the most accurate way to describe it. And the research on postmenopausal arthritis is consistent across multiple independent studies. This is not one paper. This is a pattern that has been replicated. I want to sit with that for a second. Because women are consistently told it's just arthritis, everyone gets it. But the research says women get it more, get it worse. And there are reasons for that. Biological, identifiable reasons. That matters. It does matter. And it matters because understanding the mechanism is what tells you what to actually do about it. So let's talk about what medicine is currently offering. Because I want to be honest about what works and what doesn't before we get to what's coming. Most people with joint pain get one of three things from their doctor: anti-inflammatory medication, a steroid injection, or a referral to physiotherapy. Let's take those one at a time. Anti-inflammatory medications, ibuprofen, naproxen, the drugs in that family, reduce the production of inflammatory molecules, and they work. For pain management, they genuinely work. The concern is not whether they reduce pain. The concern is what happens with long-term daily use in someone over 60, which is what most arthritis patients end up doing. Stomach lining damage, increased risk of gastrointestinal bleeding, blood pressure elevation, and for anyone with any reduction in kidney function, which becomes more common with age, the risk goes up significantly. The risk-benefit calculation looks very different for a 65-year-old using these daily versus a 40-year-old using them occasionally. And steroid injections? This one is important and under-discussed. Corticosteroid injections can produce dramatic short-term pain relief. For some patients, that relief lasts months and is genuinely life-changing in terms of function. That is real and meaningful. But a randomized controlled trial, the gold standard of evidence, published in the journal JAMA in 2017, found something uncomfortable. Patients who received repeated steroid injections over 2 years had significantly more cartilage loss than patients who received a placebo injection. Wait, the most common treatment for arthritis pain was making the cartilage worse. That is what the data showed. I want to be precise, the effect was not catastrophic, and the clinical implications are still debated. A single injection for acute pain management has a different risk profile than repeated injections every few months over years. But the point stands, the most common injectable treatment for arthritis manages the pain without addressing, and possibly accelerating, the underlying problem. And patients are often not told this clearly. They are often not told this at all.
So if NSAIDs carry real risks for older adults, and repeated steroid shots may be worsening the very thing they're treating, What about the newer, more expensive options? PRP, hyaluronic acid, the injections that get marketed as something more advanced. Are they? That's next.
Hyaluronic acid injections work by adding to the natural lubricating fluid in your joint. Think of it like topping up the oil in an engine. The joint moves more smoothly. Pain can decrease. For mild to moderate knee arthritis, some patients get meaningful relief. The effect wears off and needs repeating, and critically, it does not change what is causing the cartilage to break down. It manages the symptom without touching the mechanism.
It's buying time.
It's buying time. Used strategically alongside exercise, weight management, and strength work, it has a legitimate place. Used as a replacement for those things, the clock keeps running while the joint continues to deteriorate.
PRP, platelet-rich plasma. Everyone's talking about it right now. Clinics everywhere are offering it. What is actually happening in a PRP injection?
They take a sample of your own blood, spin it in a centrifuge to concentrate the growth factors in your platelets, and inject that concentrate directly into the joint. The idea is that those growth factors reduce inflammation and may slow the breakdown of cartilage, and there is evidence to support this. International orthopedic consensus statements have acknowledged PRP as a reasonable option for mild to moderate knee arthritis in selected patients.
So it's not snake oil.
It is not snake oil, but I want to be very precise about what the evidence shows. PRP can improve symptoms. It may slow progression. What the research does not support is the claim that PRP regenerates cartilage. Improved pain scores are not the same as new cartilage growth. Those are different things, and not every clinic drawing the distinction clearly.
And none of these treatments, not the painkillers, not the steroids, not PRP, not hyaluronic acid, touch the fundamental biological reason cartilage stops repairing itself with age.
That is exactly right. They are all working downstream of the core problem, which is why the Stanford finding is significant, because for the first time, we are looking at the core problem itself.
So here's the moment. Here's what we've been building toward. In November 2025, a team at Stanford University published a finding that the entire arthritis research world stopped to pay attention to. And when you understand what they found, in plain English, you're going to understand why. Stanford Medicine, November 2025, journal called Science, not a wellness website, not a press release. One of the most rigorous peer-reviewed scientific journals that exists. The researchers published a paper that said this: cartilage in aged joints can regenerate, and they showed exactly why it hasn't been, and what is blocking it.
The lead researchers were Nidhi Bhutani and Helen Blau, both from Stanford's Baxter Laboratory for Stem Cell Biology. This was not a brand new idea for their lab. In 2021, the same group published a paper showing that a specific type of enzyme, one that builds up as we age, was actively suppressing the body's ability to repair muscle, bone, liver, and colon tissue in older animals. When they blocked that enzyme, the tissues started repairing again.
Like flipping a switch back on.
That is almost exactly how the lead researcher described it. And the 2025 study asked, does the same thing happen in cartilage? They tested it in two ways. First, in aged mouse joints and in surgically induced arthritis models. Then, and this is the part that separates this study from most animal research, they tested it in human cartilage tissue removed from real patients during knee replacement surgery.
Human tissue, not just mice.
Human tissue. And in both cases, when they blocked the enzyme, the cartilage cells responded. They began behaving the way younger, healthy cartilage cells behave. The repair process, which had been switched off, started switching back on.
So cartilage does have the ability to repair. It just gets switched off.
That is what the evidence suggests. It is not that your cartilage cells have forgotten how to work. Something is blocking the signal they need to do their job, and that something is a specific, identifiable, targetable enzyme.
So what is this enzyme? What does it actually do? And why does it build up as we get older? Because when Suki explains this, and she's going to explain it simply, everything about your joint pain is going to make a different kind of sense. Stay right there.
Here is the mechanism in plain English. Your cartilage cells need a signal to do their maintenance and repair work. Think of that signal like a text message. It tells the cells, time to rebuild, time to fix the damage. Without that message, the cells sit idle, the damage accumulates, the tissue thins.
And the enzyme is what's deleting the messages.
Exactly. The enzyme breaks down that repair signal before it can reach the cells. When you are young, this enzyme is present at low levels. The signal gets through, the cells do their work, and minor damage gets repaired. As you age, the enzyme accumulates. Its levels rise in your joint tissue. The more of it there is, the faster it destroys the repair signal, until eventually the signal disappears almost entirely, and the cells stop receiving instructions to repair.
So it's not that the repair machinery is broken. It's that someone keeps cutting the phone lines.
That is a precise analogy. The machinery is still there, the cells are still capable, but the instruction, the chemical message that tells them to activate, is being intercepted and destroyed before it arrives.
And this is what the Stanford team found in both the animal joints and the human tissue samples?
Correct. They found this enzyme, called 15-PGDH, though the name matters less than what it does, elevated in aged and arthritic joint tissue. They found that blocking it restored the repair signal, and they found cartilage regeneration in tissue that had been effectively dormant.
This is the part that I keep coming back to, because it completely changes the framing. The old story was, your cartilage is worn out, you're too old, it's gone. The new story is, your cartilage cells are still there, they still know how to work, something switched them off. And we now know what that something is.
We are not making a reversal claim here. We are not saying this is a cure. What we are saying is that the assumption that cartilage degeneration is an irreversible, unstoppable process is based on incomplete science. And the new science opens a door that was previously thought to be locked.
And someone is already building the key. There is a drug in human clinical trials right now targeting this exact enzyme. And when Suki walks you through where that trial stands as of 2026, you're going to want to know this, because the timeline is closer than you think.
A biotech company called Iperium Bio has developed a drug called MF300. It is a pill, not an injection, that targets and blocks the enzyme we just described. The same enzyme Stanford identified, and it is already in human clinical trials.
When you say already in human trials, where does that stand right now?
In September 2025, Iperium announced positive Phase 1 results in healthy volunteers. In January 2026, this year, they published positive Phase 1 results, specifically in older adult participants. Phase 1 is about safety. It tells us the drug appears to be safe and well tolerated at the doses tested. It does not yet tell us whether it produces meaningful cartilage regeneration in patients with established arthritis.
So it's safe. We don't yet know if it works in humans with arthritis.
That is the precise, honest summary. Phase 2 and Phase 3 trials, which test whether it actually works for osteoarthritis in real patients at scale, have not yet been completed. Helen Blau, the senior researcher on the Stanford study, stated in an interview that a human osteoarthritis trial is 2 to 4 years away if everything goes well.
2 to 4 years, that's not tomorrow.
It is not. And clinical trials can fail for reasons entirely unrelated to the quality of the underlying science. That is the honest reality of drug development. What we can say is, the mechanism has been validated in animal and human tissue. The drug is in human trials. The safety data is positive. The lead researchers are credible. The journal is credible. The institution is credible. This is not a headline that leads nowhere. This is a legitimate pipeline.
And for someone in their mid-60s right now, if that trial succeeds, this could be available while you're still in your late 60s or early 70s, which means the question becomes, what do you do in the meantime? And that, honestly, is the most practically useful part of this entire episode. Because the biology we just walked through has direct implications for choices you can make this week. The same pathways, the same mechanisms, things that are available to you right now, not in 2 years. Suki is going to give you the specific steps, and I want you to notice that the first step is not buying anything.
The most useful first step is not to go and buy supplements. The most useful first step is to ask your doctor for a blood test, specifically your vitamin D level and 2 inflammation markers called CRP and ESR. Here is why those 3 numbers matter.
Start with vitamin D.
Multiple studies have linked low vitamin D levels to faster cartilage loss in arthritic joints. A 2009 study published in the Journal of Clinical Rheumatology found that people with low vitamin D levels showed significantly more cartilage deterioration on X-ray over time. Vitamin D deficiency is extremely common in adults over 60, particularly in people who spend limited time outdoors. It is easy to test for. It is easy to correct with a supplement if levels are low, and it costs almost nothing.
That is the lowest hanging fruit in this entire episode. Get that number.
Get that number. If it is low, work with your doctor to correct it. That is step 1.
Step 2, the inflammation markers.
CRP and ESR are general markers of inflammation in the body. High levels tell you that your body is running hot. There is an ongoing inflammatory process that is working against your joints, your heart, and your metabolic health simultaneously. Knowing whether you have elevated inflammation changes your priorities, and it gives you a baseline to measure improvement against.
Step 3, diet, specifically the fat balance.
The repair signal that the Stanford enzyme is blocking, the one we described as the text message to your cartilage cells, is made in your body from building blocks that come directly from the fats you eat. A diet high in processed vegetable oils and low in oily fish tips that balance toward inflammation. A diet with more omega-3, oily fish, flaxseed, walnuts, tips it toward repair. A 2015 analysis of 12 separate clinical trials found that omega-3 supplementation produced significant reductions in joint pain and morning stiffness compared to placebo.
So increasing omega-3 is literally feeding the same repair pathway that Stanford identified.
It is supporting the same biochemical network. I want to be precise. A dietary change is not the same as a pharmaceutical enzyme inhibitor. The effect sizes are not comparable, but it is a real evidence-backed intervention that supports the same underlying biology. And unlike the drug pipeline, it is available today.
And then there is step 4, movement, which is where most people over 60 have been given completely wrong advice for decades, because every instinct says, if it hurts to move, rest it. And the research says that instinct is making it worse. Here's why.
Your cartilage has no blood supply. We said that earlier. So the question is, how does it get its nutrients, oxygen, proteins, the building blocks it needs to stay healthy?
If there's no blood supply, how does anything get in?
Through movement. When you bend your knee, sit down, stand up, walk, the cartilage gets compressed and then released. That compression and release acts like a sponge being squeezed and relaxed. The joint fluid, which carries the nutrients, gets pumped in and out of the cartilage tissue. That is how cartilage feeds itself. It has no other option.
So when you stop moving, when you rest a painful joint for weeks or months,
the cartilage stops getting fed. The tissue begins to thin from malnutrition, not just from use. The joint fluid stagnates. The inflammatory environment becomes more concentrated. The pain often gets worse over time, not better. Rest feels intuitively right because movement hurts, but chronic rest is accelerating the problem it is trying to solve.
I know people who have been living with knee pain for years, and they genuinely believe that if they exercise on it, they will destroy it.
This is one of the most damaging beliefs in arthritis management. A Cochrane review, a meta-analysis of multiple high-quality clinical trials, found that structured exercise for knee arthritis produced reductions in pain and improvements in function comparable in magnitude to anti-inflammatory medication, not instead of in addition to. Exercise is not a consolation prize for people who can't take medication. It is a first-line intervention with evidence as strong as any drug on the market.
What kind of movement are we talking about?
Low-impact movement that loads the joint without excessive force. Walking, swimming, cycling, resistance training with careful progression. The goal is not pain-free movement. Some discomfort during exercise is expected and acceptable. The signal to stop is sharp pain that gets worse during activity and does not settle within a day.
And resistance training, building muscle around the joint?
This is the non-negotiable piece. The muscles around your knee, particularly the large muscles at the front of your thigh, are your joint's shock absorbers. Every step you take sends force through the knee. When the surrounding muscles are strong, they share that load. When they are weak, the joint absorbs it alone. Studies consistently show that people with stronger thigh muscles have slower arthritis progression, better function, and less pain. For women over 60, building that muscle strength is not optional, it is foundational.
4 minutes of targeted resistance work per day consistently outperforms hours of rest. That is the counterintuitive truth.
But I want to address something before we close, because I know some of you are thinking, this is all well and good, but my arthritis is already advanced. Is any of this still relevant for me? And the answer to that question changes how you think about everything we've covered today. Don't go anywhere.